Hello, Dr. Tang.
Hello, John.
How are you?
Nice to meet you.
Nice to meet you. Yeah, when I saw you on the other webcast and I saw the topic you were talking about, I said, well, I've got to ask him to come on, by himself. Are you from Beijing or Shanghai?
I'm from Beijing.
Okay, so the Chinese PLA hospital is in Beijing.
Yes,
Okay, big hospital, right?
yes.
Okay. Okay, we start in 10 minutes, 12 minutes, okay?
Okay, 10 minutes later.
Okay, I'll be back.
Yes,
I just have to do some things, okay?
okay.
Mm. Hello, Zanab.
Hello.
Yeah, we just start in a few minutes, Dr. Tang. So how big is, you're in a neurosurgeon, and have you finished your residency? Can you hear me okay?
Yes.
Have you finished your residency? Can you understand? No, you can't. Can you hear me okay?
Yes, I can hear. I can hear you.
Oh, okay. Okay, how big is your department?
Oh, my department is neurosurgery.
Oh, okay. How many neurosurgeons on staff?
14 member.
40? How many use gamma knife?
Beg your pardon.
How many use gamma knife?
They are busy in working.
Oh, okay. 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 Okay, you ready to start?
Yes.
Ready? Okay.
Yes,
Here we
3
go.
minutes.
Okay, let me introduce you, okay?
Yes, my name is Tang.
Yeah, Chinese PLA hospital.
Yes, Chinese
And
PLA Hospital.
today
Department
you
of Neurosurgery.
Department of Neurosurgery,
Yes.
and you're going to talk today about how to use microsurgical anatomy in the plan of gamma knife surgery.
Yes.
Okay. Okay. Let me start. Wait. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good
Okay.
morning from Miami Beach. This is Dr. John Bennett. We have the pleasure of broadcasting from Beijing, China. We have neurosurgeon Tang from the Chinese PLA hospital. And today, I met Tang at another webcast. He was doing a webcast with Ben Zhu. And so I asked him to do this one. So he was nice enough to do that. And today he's going to talk, as you see, how to use microsurgical anatomy in the plan of gamma knife surgery for skull base lesion. And we'd like to thank Tang for taking the time to give us this lecture. And welcome, Tang.
Thank you, Sensei. I will begin my report. Yes.
Yes.
Dear professors, members, thank you very much. It's my pleasure to stand here and introduce some of my work. My report was how to use microsurgical anatomy in plan of gamma knife surgery for skull-based lesion. As we know, microsurgical anatomy is a key point to decrease injury risk intraoperatively. Can direct dissection is a traditional approach to acquire information about neurovascular protection. However, the cadaveric dissection is a hard work, not convenient, and cannot provide individualized guidance. So we try to establish three-dimensional anatomic model. On the cadaveric head of anatomic laboratory, reconstructed images of osseous, the bony structures, were extracted from the CT data, obtained prior to the artery and the vein perfusion. Reconstructed images of the brain tissues were also extracted directly from the MRI data obtained prior to cadaveric dissection. Reconstructed images of the artery were obtained from the CT data obtained after arteries perfusion. Reconstructed images of the veins were obtained from the CT data obtained after vein perfusion. Then, three-dimensional images of the cranial nerves were extracted from the MRI data obtained after cadaveric dissection. Each structure was distinguished by coloring to establish a model. We can see the observed results of the three-dimensional model from multimodal imaging were consistent with those of cadaveric head, and the three-dimensional anatomic model can be used to make surgical planning. We also use multimodal imaging to conduct lesion-specific modeling for the path planning of microsurgery. Briefly, we also use data of MRI and CT to establish model. The MRI protocols include the T1 weighted sequence, contrast-enhanced T1 weighted sequence, T2 space sequence, and time of flight TOF sequence. In addition, we performed rigid registration to align all images and outline the contours of the lesions, osseous, and neurovascular structures. Then, how to use imaging for anatomic analysis? When we meet the question, reappearance of AVM after complete resection of ruptured AVM, true recurrence or false negative early postoperative imaging results. Let's discuss this case. The DSA shows that the AVM feeding artery included the posterior parietal artery and the angular artery arising from middle cerebral artery, supplying the nidus laterally, and the parietal occipital artery arising from posterior communicating artery on the carotid angiography imaging, supplying the nidus medially. The drainage veins included the vein of Cholat, connecting to the nidus laterally and superiorly and draining into the cerebral sagittal sinus. The vein of Levy, connecting to the nidus laterally and inferiorly and draining into the transverse sinus, and the middle temporal basal vein, connecting to the AVM nidus medially and inferiorly, and also draining into the transverse sinus. The areas involved by the AVM might have included the angular gyrus and the superior occipital gyrus laterally, and the cuneus and precuneus medially. Based on the above anatomic analysis, we postulate that the reappearance of the AVM might be due to a remnant that was left after the surgical procedure. A parietal craniotomy might have been performed, and the resection might begin with the lateral part of the nidus, following the occlusion of the parietal artery and the angular artery. The dissection of the major nidus would then be achieved. In this scenario, the vein of Cholat and the vein of Levy connecting to the nidus laterally could have been separated successfully, but the medial fragment, the portion of the nidus, might have been remained hidden due to the deeper location in the precuneus. Vasospasm or edema might then have masked this remnant on the angiographic image obtained 7 days post-operative. As the illustration shows, the recurrent AVM was located in the inferior portion of the precuneus, and was supplied by the parietal occipital artery and drained by the middle temporal basal vein, which would both be located in the deeper surgical field. We believe that microsurgical anatomy plays a dominant role in every AVM recurrence. Preoperative and intraoperative anatomical analysis is important for the complete resection of AVM and prevention of the recurrence. Anatomic identification on the imaging is another key point. For this case, we want to talk about this DTI force, the run from the views of the neural anatomy. According to the rule of neural connections, the nerve fibers consist of axons from the neurons. Thus, the fibers of cranial nerve 3 arise from the oculomotor nucleus and the VE nucleus to connect the intraocular and extraocular muscles, whereas the fibers of the medial longitudinal fasciculus mainly arise from the vestibular nucleus to connect the oculomotor nucleus, trochlear nucleus, abducens nucleus, accessory nucleus, and the anterior horn neurons of the cervical cord. Mutual connections between the above nucleus and the brainstem and the spinal cord also exist in the medial longitudinal fasciculus. Synergic movement of the ocular and neck muscles is controlled by the above connection of the medial longitudinal fasciculus. Direct connections between the medial longitudinal fasciculus and the ocular muscle do not exist. Obviously, it is also a false continuation of the fibers of cranial nerve 3 arising from the medial longitudinal fasciculus directly. Axon cannot arise from axon directly. Limitations and potential artifacts associated with the technique can provide false and misleading information. Thus, careful anatomic analysis, especially microsurgical anatomy, is therefore essential to avoid the force of imaging. Then, we use multimodal imaging to make anatomic analysis for the plan of gum-knife radiosurgery. Diagnostic MRI co-registered with stereotactic CT can be used for accurate target location. When we use stereotactic CT, the mean area of the fiducial position is 0.1 millimeter. The maximum area of the fiducial position is 0.2 millimeter. CT scans can avoid geometric distortion and provide accurate stereotactic space by precisely defining the fiducial nucleus. Multimodality MRI imaging can help to define the neurovascular structures. A satisfactory imaging fusion can be done if the cranial nerves shown in the MRI fit smoothly into the scar fragments shown in the CT. So, precise target localization can be realized by a combination of accurate stereotactic space in CT and clear anatomic identification in MRI. The application of multimodality imaging co-registration to stereotaxis avoids the problem of additional intraoperative MRI and reducing the time of stereotactic head frame immobilization. There are some examples to show that precise target localization can be realized by combining accurate stereotactic space in CT and clear anatomic identification in MRI. The validation of the co-registration accuracy with scar-based fragment is recommended. Firstly, let me show how to align the pixels of scar-based fragment with the cranial nerves they contain. The superior orbital nerve and the superior orbital fragment or notch in axial section. The superior orbital nerve fits in the superior orbital fragment or notch in coronal section. and in sagittal section. Then the optic nerve and the optic canal in axial section. The optic nerve fits in the optic canal in coronal section and in sagittal section. Next, the infraorbital foramen and the infraorbital nerves in axial section. The infraorbital nerve fits in the orbital foramina in coronal section and in sagittal section. We can see. Then the maxillary nerve and the jodantrum foramen in axial section. The maxillary nerve fits in the jodantrum foramen in axial section, in coronal section, and in sagittal section. Then the mandibular nerve and the oval foramen in axial section. The mandibular nerve fits in the oval foramen in coronal section and in sagittal section. Then let's see the radial nerve and the radial canal in axial section. The radial nerve fits in the radial canal in coronal section and in sagittal section. Then internal acoustic matters and the cranial nerves 7 and 8 in axial section. The cranial nerves 7 and 8 fit in the internal acoustic matters in coronal section and in sagittal section. Thus, we verify co-registration of MRI and CT data. The validation of precise localization of targets can be shown in the gum knife treatment of trigeminal neuralgia. As we know, the trigeminal nerve has ophthalmic branch, maxillary branch, mandibular branch. If the high dose of gum knife targets the branch precisely, we will achieve satisfied pain relief. The case 1, female, 66 years old. She has medically refractory trigeminal neuralgia in right side, and the pain located in the mandibular area. The three-dimensional neurovascular anatomy shows the relationship between the trigeminal nerve and corresponding vessels. The corresponding vessels are the ring of the middle cerebellar peduncle and superior petrosal vein. We performed gum knife surgery. 63 gray in 70 gray isodose lamp, 19 gray in 100% isodose lamp. Target localization in the cross-section of the mandibular branch. The earlier analgesic effect was shown in the visual analog scale at 2 days following gum knife surgery. The patient could brush her teeth and washing her face, which supported the validity of CT stereotaxis combined with multimodality imaging co-registration. Stable analgesic effect was also achieved for this case. Barrow Neurological Institute Pain Intensity Scale, the BNI scale, class 1 at last follow-up, we can see, at 5 years following gum knife surgery. The case 2, female, 78 years old. She has medically refractory trigeminal neuralgia in right side, and the pain located in the maxillary area. The three-dimensional neurovascular anatomy shows the relationship between the trigeminal nerve and corresponding vessels. The corresponding vessels was a superior cerebellar artery and the superior petrosal vein. We performed gum knife surgery, 63 gray in 70% isodose length, 90 gray in 100% isodose length. Target localization in the cross-section of the maxillary branch. The early analgesic effect was shown in the visual analog scale at 2 days following gum knife surgery. The patient also could brush her teeth and washing her face, which supported the validity of CT stereotaxis combined with multimodality imaging co-registration. Stable analgesic effect was also achieved for this case. Barrow Neurological Institute Pain Intensity Scale, BNI Class 1 at last follow-up, 5 years following gum knife surgery. The isocenter with high dose such as the dose as 19% to 100% isodose length should accurately reach the ideal site on the pain area of cranial nerve 5 to result in the appropriate level of axon degeneration. CT stereotaxis combined with multimodality imaging co-registration offers a combination of geometric accuracy of CT and the satisfactory anatomic identification of MRI. It contributes to the outcome of gum knife for treatment of trigeminal neuralgia. With the application of this technique, there was no need to perform additional intraoperative MRI, and the duration of stereotactic head frame immobilization is shortened. In addition, clear display details of neurovascular complex on high-field strength MRI will help determine the appropriate isocenter position. The precise co-registration of multimodality imaging can be implemented by pixel-to-pixel alignments according to the various anatomic landmarks in skull base. Let's say the case 3, male, 24 years old. He suffered diplophial dysfunction of left eye bone abduction following the head trauma. MRI showed carotid cavernous fistula in the left side. We failed to perform DSA for the case because of the severely ideal allergy. We can see the dysfunction of the left eye bone abduction. Then we perform gum knife surgery. The three-dimensional neuroanatomy showed the internal carotid artery, vestibular orifice, venous dilation, cranial nerve 5, trigeminal nerve, cranial nerve 6, abducens nerve. Prescribed dose, it was 15 gray at 30% isodose length. We made shots in the site of vestibular orifice and venous dilation, and the shot avoided cranial nerve 5 and cranial nerve 6. We made dose protection for the cranial nerves. The post-gum knife surgery MRI showed successful obliteration of the fistula. Recovery of cranial nerve 6 dysfunction was achieved at 6 months following gum knife surgery. We can see the normal eye bone abduction. At last follow-up, we can see the normal function of cranial nerves. The case 4, female, 43 years old. She suffered ptosis and diplopia in the right side. MRI showed the ocular schwannoma. We performed gum knife surgery. The three-dimensional neural anatomy showed the lesion, the optic nerve, oculomotor nerve, trochlear nerve, trigeminal nerve. Prescribed dose was 15 gray at 30% isodose length. We set short avoiding the cranial nerves and made dose protection. The post-gum knife MRI showed tumor shrink. Recovery of cranial nerve 3 dysfunction was achieved at 1 year following gum knife surgery. We can see the normal function of cranial nerves at the last follow-up. The case 5, female, 53 years old. She had numbness in the left face. MRI showed a lesion in the posterior part of cavernous sinus. It was trigeminal schwannoma. We performed gum knife surgery. The three-dimensional neurovascular anatomy showed the lesion, the optic nerve, oculomotor nerve, trochlear nerve, trigeminal nerve, abducens nerve. Prescribed dose was 14 gray at 13% isodose length. We set short avoiding the cranial nerves and made dose protection. The post-gum knife surgery MRI showed the tumor shrink. Sensory recovery in the left face was achieved at 1 year following gum knife surgery. We can see the normal function of cranial nerves at the last follow-up. The case 6, female, 54 years old. She had numbness in the right face. MRI scan showed a lesion of cavernous sinus. She underwent craniotomy, but only biopsy was done for the cardiac arrest in the operation. The pathology reports showed meningioma WHO1. The volume stage of gum knife radiosurgery was designed. Stage 1. Prescribed dose was 40 gray, 30% isodose length. The dose focused on the posterior part of the lesion. We used the multimodal imaging to show the neurovascular structures surrounding the lesion. We could see cranial nerve 3 to 5 distortion and make those protection for the cranial nerves. To achieve tumor bed effect, we also set high dose on the Banasconi catenary artery, the supplying artery of the posterior wall of the cavernous sinus. Volume stage 2. Prescribed dose was 14 gray, 30% isodose length. The dose focused on the anterior part of the lesion. We also make dose protection for the cranial nerves. To achieve tumor bed effects, we set high dose on the inferior lateral trunk of the internal carotid artery, the supplying artery of the lateral wall of the cavernous sinus. The post-gum knife surgery of last follow-up showed tumor control at 4 years following gum knife surgery. We achieved sensory recovery in the right face at 1 year following gum knife surgery. And conservation of normal function of cranial nerves was also achieved at the last follow-up. We can see the normal oculomotor function. The case 7, female, 26 years old. She had hearing loss in right ear and was diagnosed with neurofibromatosis. MRI showed bilateral vestibular schwannomas, right trigeminal schwannoma, meningioma in the left frontal lobe, Fox, right occipital lobe. The hearing of the left ear was normal. The hearing of the right ear reduced to 16%. Gum knife surgery was performed. Schwannomas with prescribed dose 12 gray, 30% isodose lamp. Meningioma with prescribed dose 12 gray, 50% isodose lamp for the Fox right occipital lobe lesions. The 12 gray, 55% isodose lamp for the left frontal lobe lesion. We reconstructed the imaging of the three-dimensional imaging of facial nerve, acoustic nerve, superior vestibular nerve, and inferior vestibular nerve, and make dose protection. The maximum dose of acoustic nerve was less than 8 gray for both sides. All lesions were controlled at 3 years following gum knife surgery. All the schwannomas were controlled at 5 years following gum knife surgery. At last follow-up, a new lesion in the jugular foramen was found, and the meningioma in the left frontal lobe relapsed. The radiation dose of this meningioma was insufficient. It might be a lesion that the prescribed isodose lamp was set to 55% for this lesion. Fortunately, the other lesions were controlled well. The hearing of the left ear kept normal. The test score of the hearing of the right ear was somewhat increased. We could see the successful conservation of the hearing for the bilateral vestibular schwannomas. Using multimodal imaging, we perform visualization of the microsurgical neurovascular anatomy surrounding the lesions. The imaging of T1-weighted secrets and T2 space secrets showed the cisternal segments of cranial nerves. The top secrets showed artery. The high signal of contrast enhanced T1-weighted secrets was used to show the vein, and the cavernous sinus segment of cranial nerves was shown as lower signal on the background of high signal of vein. We can see the three-dimensional anatomy of scar-based neurovascular structures for pituitary adenoma, meningioma, and schwannomas. We can see the tumor control. The neurovascular protection was satisfied. In summary, multimodal imaging with imaging fusion can be used to show the microsurgical anatomy of neurovascular structures and set sufficient dose to treat lesions and make dose protection for the neural function. The protection of neurovascular structures depends on the pair of neurovascular tolerated radiation dose and lesion effective control radiation dose. On the basis of visualization of the microsurgical neurovascular structures, it will be interesting to compare the traditional physical dose parameters and the three-dimensional biological effective dose parameters in future studies. Thank you sincerely. I finished. Thank you.
Okay, great, Dr. Tang. Thank you very much for taking the time to put together such a good presentation. And now I'm going to ask the audience if they have some comments or questions. Does anybody have any comments? Abdallah or I'll stand by. Harshad. Harshad, are you there? Perhaps he stepped away. Zanab, are you there? Everybody is on mute. Tang, Dr. Tang.
Hello, John.
Oh, okay, great. How you doing, Harshad?
I'm doing fine. Excellent lecture.
Okay, you got your microphone went.
Trigeminal neuralgia. When you give a gamma knife to trigeminal neuralgia, how long does it take to give a result of pain-free trigeminal neuralgia? How long? The period?
Did you understand, Dr. Tang?
Pardon?
Yeah. He has a kind of a problem hearing, understanding.
Trigeminal
Harshan,
neuralgia.
could you repeat it to me, please? I can tell him.
In a case of trigeminal neuralgia,
Oh,
Okay.
yes, trigeminal neuralgia.
yeah,
Yes.
when you give gamma knife,
Okay.
how long it takes to give a result of pain-free trigeminal neuralgia?
Oh, okay. Okay, Dr. Tang, Dr. Harshad Parekh, he's a neurosurgeon from India. He asked, in trigeminal neuralgia, how long does it take to see improvements in the pain?
Okay. I see. I began this work at 2014, and the duration of the pain more than 1 year, and the duration of the pain is commonly 3 to 5 years, and if he has medical refractory trigeminal neuralgia, we perform the gamma knife for these cases.
I'll make a comment. Dr. Parekh, trigeminal neuralgia seems to be pretty common.
Yes.
Do a lot of neurosurgeons see that, or is it just like a subspecialty that sees those types of patients? Harshad, are you there? Did you hear me?
The release of a pain after the John.
Oh, okay.
Hello?
Yeah, I can hear you. Go ahead. Go ahead, Harshad.
Hear me? Can you hear me?
Yes, now we can.
John, whenever
Yes.
the treatment is given, the pain relief doesn't
Pain
come
relief.
instantly. I am asking how much is the pain?
The pain relief.
What is the time
The
scale?
pain relief.
Yes.
The pain relief.
Yeah, what's the pain scale? Is that what
Yes.
you're asking, Dr. Parekh?
The visual analog scale.
John, I'm
And
asking.
The visual analog
No.
scale and 100 millimeter. The length of the scale is 100 millimeter. And as we know, the microsurgical for trigeminal neuralgia will get the more earlier analgesic effects, but the earlier analgesic effect is late if we perform gamma knife. But sometimes if we precise target the location, the edema of the roots of the cranial nerve 5 will let me achieve the earlier analgesic effects. So some patients pre-gamma knife cannot brush her teeth or washing her face, but the 2 days following this gamma knife, if we make precisely localization of the targets, she can washing her face and brush her teeth at 2 days following gamma knife surgery.
Okay, thank you. Thank you for the question.
Yeah. Okay, thank you.
Thanks, Dr. Parekh. Does anyone else have some comments before we close? Abdallah, okay. Well, okay, I'd like to thank you, Dr. Tang, for taking the time. And we'll send you an edited copy of this video, okay?
Thank you for this good opportunity. Thank you.
Okay, and we keep in touch, okay?
Yes, okay. Keep in touch. Thank you.
Okay, thanks everybody for coming, and we'll see you soon.